Welcome back. In today's session, we are going to discuss about malaria. It is a continuation to the topic epidemiology of communicable diseases. The objectives of today's session is introduction to malaria, problem statement, epidemiological determinants which includes the agent factor, host factor and also the environmental factor. We'll also discuss about the vectors of malaria, an important one, the mode of transmission, incubation period, pathophysiology, and we'll also discuss the medicine aspect. As I have told you very clearly that in one lecture we will discuss main importance will be given to the social and preventive medicine, followed by we will discuss about the medicine aspect which includes the pathophysiology, clinical features, diagnosis. Then we will also cover the pathology and physiology, which will include the pathophysiology. Then you can also study about the life cycle of that disease, and then we will discuss the measurements of malaria, approaches how we can control the malaria, the prevention of malaria, how we can prevent the malaria, the treatment and also the management of the cases, and lastly the summary. We will quickly check how much we have gained knowledge about each of the topic and how clear the concept is to us. So let's start the introduction. Okay, with a fresh start we are starting about the introduction. Malaria is derived from the italic word. Okay, it is derived from the italic word mala, means bad, and area means air. So malaria is nothing but the bad air. Okay, Ria or AIR, the reverse of it. Okay, bad air. It is a protozoal infection. The disease is caused with the parasite of the genus Plasmodium, and it is a protozoal disease. Malaria is a mosquito borne febrile disease. Okay, how is it borne with? It is caused by the mosquitoes. They are the vectors here. Okay, a mosquito borne febrile disease. The patient presents with fever, basically fever. So malaria is a protozoal disease. It is a mosquito borne febrile disease. It is caused by the malaria parasite. So what is the causative organism here? We understood that malarial parasite is the causative organism, and we have the mosquito acting as a vector causing the febrile disease. A disease is caused by the members of, so the malaria disease is caused by the members of protozoan genus Plasmodium. It is caused by the protozoa genus Plasmodium. Okay, genus Plasmodium belongs to the genus Plasmodium, a widespread group of sporozoans that parasites affect the human liver and red blood cells. So, when we discuss the pathophysiology, you will get a clear understanding about the sporozoans and how the sporozoans will affect the human liver and red blood cells. From here in this slide, what we understood, it's belonging to the genus Plasmodium, and it is causing the infection is caused by the sporozoans. They are parasiting the human liver and red blood cells. Humans are infected with the Plasmodium protozoa when they are bitten by an infective female Anopheles mosquito vector. So as I explained you earlier, the disease basically is affecting the humans. The humans are the host, and this female Anopheles mosquito, the female Anopheles mosquito will bite the humans, and this female Anopheles mosquito is containing the genus Plasmodium. Okay, the genus Plasmodium, and this Plasmodium protozoa, genus Plasmodium protozoa. Now in this plasmodium we will see the various types: plasmodium vivax, ovale, and so on in the next slide. So we understood that the malarial parasite is found in these Anopheles mosquitoes. They are acting as a vector. First is this parasite. Okay, first is the parasite, and this parasite is taken up by this female Anopheles mosquito, which is just acting as a vehicle to transmit the infection to the humans. And then the symptoms may appear within weeks to months, or it may even take up to years to show the symptoms. Now we'll move forward to the problem statement. I hope the introduction is clear. The malaria is derived from the Italic word, so we know that mala means bad and area means bad air. And the mosquito, it is a mosquito borne febrile disease. Which mosquito is causing this? The female Anopheles mosquito acting as a vector, and it is caused by the malarial parasite. This malaria parasite belongs to the genus Plasmodium. Okay, it belongs to the genus Plasmodium, and this plasmodium, in that the sporozoans are going to affect the livers and red blood cells. So this is what we understood. Next we see malaria remains the world's most devastating human parasitic infection. So it is a world's most devastating, a parasitic infection. It is affecting over 40% of the world's population. You can see the 40% of world's population is being affected by malaria. And the World Health Organization estimates that there are 350 to 500 million cases of malaria worldwide. 350 to 500. Okay, 350 to 500 cases of malaria worldwide. In India, 2 million cases and 1000 deaths occur annually. So in India, when you see specifically in India, okay, let's zoom in. So we have India. In India, we have 2 million cases, 2 million cases and 1000 deaths a year. Is it clear? Next, we will move further. Okay. The specific risk groups for malaria: young children in stable transmission areas who have not developed the protective immunity against the severe disease. So we see that the young children are more prone to develop this infection. It is because these young children do not have a well developed immunity. And the non-immune pregnant women, so this non-immune pregnant women are contradicted with malaria more, because they have a high risk of miscarriage and can lead to maternal deaths as well. So what happens again in the pregnant women? There is an altered immunity. The physiological changes will take place, and lots of physiological changes, and the reduced immunity is causing to an increased incidence of this malaria infection in the pregnant women, and this infection is causing a higher rates of miscarriages, and it is also leading to maternal deaths. Is it clear? And then we also see that the semi-immune pregnant women in the areas of high transmission, where there is a high transmission of malaria, the semi-immune pregnant women will be more affected. The semi-immune HIV infected pregnant women, again in HIV, the immunity will be compromised. The immunocompromised people are more affected. Okay, those with the low immunity, the infants and the children, they do not have a well developed immunity because the exposure is low. So young children, you can write there is group young children and non-immune pregnant women, semi-immune pregnant women, semi-immune HIV infected pregnant women. Okay, and people with HIV and AIDS who are having a immunocompromised immunity system. And we have international travelers from the non-endemic areas, because again they lack the immunity, they are more prone. Okay, the international travelers, so these international travelers, they are never exposed to the malaria, so the semi infection also has never occurred, they have never been exposed to the malarial parasite. So these international travelers who are belonging to the non endemic areas, because they lack the immunity, are more prone. Is it clear? Next, we will move further to the epidemiological determinants. Okay, the epidemiological determinants, as I told you, it belongs to the genus Plasmodium. Under Plasmodium, we have the parasites, the Plasmodium vivax, Plasmodium ovale, Plasmodium falciparum, and Plasmodium malariae. Is it clear? VOFM. Okay. Okay, can you yeah, VOFM. So we have Plasmodium vivax, Plasmodium ovale, Plasmodium falciparum, and Plasmodium malariae. I hope it is clear. The agent factors, we have seen the agent factors. Now we'll move further to the host factors. Then in the host factors, we see that we have the age. Malaria affects all ages. Newborn infants have a considerable resistance to infection, P. falciparum. So we see that in the newborn infants, they get the antibodies transfers from the mother through the placenta, and then soon after their birth they have some immunity against this parasite. So the malaria affects all the age groups. Newborn infants, especially the newborn infants up to 3 months, okay, up to 3 months will have the resistance to the infection P. falciparum, because of the uh, antibodies which are transmitted from the mother to the baby, from the mother to the baby via the placenta. Okay, and then we see that males are more frequently exposed to the risk of acquiring malaria compared to the females. It is because the males are more commonly working in outside the setups, so they work in the open fields, in the especially the irrigation farming. In India, we know that the most of the people are seen to be employed in farming. They are seen to be doing the farming and agriculture, so they'll be working in open fields. And improper covering of the body, not taking proper measures, this will lead to the frequent exposure, and males are more commonly seen to be exposed to the risk of acquiring malaria compared to the females. Then we'll see the race. Individuals who are having the sickle cell trait have a milder illness with falciparum infection. Persons whose RBC is Duffy negative are resistant to the P. vivax. So we see that the sickle cell trait, here, the sickle cell trait are known to have a milder illness with falciparum infection, because their RBC is already affected, so it is more prone to get destructed by the spleen, and the parasite does not get enough time to multiply in the RBC. Are you understanding? So what happens? This malarial parasite basically affects the RBC. In sickle cell and all, the RBC shape is changed to oval. So the RBCs get secretized in the spleen and the liver. So in the spleen, the secretration happens. The capillaries will not filter these RBCs. They are known to have a milder illness. Whose RBCs are Defi negative are also resistant to the P. vivax. Then comes the socio-economic development. It is generally accepted that malaria disappeared from the most developed countries. So in the most developed countries, the hygiene practices will be increased. They do not store water in local pots and everything. They are aware of this malaria spreading from the contaminated water. It is because of the increased awareness and the hygiene, good hygiene practices, and modernization, urbanization, and we also have the increased health facilities. Okay, the increased health facility in the urban areas and the developed areas, developed countries. So the malaria is so slowly disappearing in these countries. And then we'll see the housing, ill ventilated, ill lighted houses. So they will become an ideal indoor resting place for the mosquitoes. So it is very important that the ventilation should be proper, the windows should be opposite to that of the doors. So the ventilation should be properly placed. Okay, the windows, and this is the door. The proper ventilation is necessary, and the lighting is also necessary to prevent the mosquitoes growth. So the ill ventilated areas, ill lighted areas, so these areas will become ideal door for resting place for mosquitoes. And then comes occupation. It is predominantly a rural disease. As I told you earlier, the farming, there is a stagnant water placed in the water in the fields, isn't it? So we have the stagnant water which becomes a breeding ground for the mosquitoes, and it is closely related to agriculture. So in the rural areas, the malaria is said to be more in number. Is it clear? The malaria cases are increased. Next, we will move further to the environmental factors. In the environmental factors, we see that we have the seasonal disease. In most part of India, the maximum prevalence is seen from July to November. So the malaria is said to be more in cases of the period between July to November. And then we will see the humidity. Humidity of 60% is considered necessary for the mosquito to live the normal span of life. So the humidity also plays a role. The mosquitoes require the proper season, proper temperature, and the proper humidity to survive. So we see that a humidity of 60% is necessary for the mosquito to live in a normal span of life. Then we have the rainfalls. Rainfalls are providing an opportunity for the mosquitoes to breed. Okay, and this will give rise to an epidemic, the rainfall season. Okay, you can also correlate with the season, the rainfalls. And we have the altitude above 2000, the altitude above 20,000 to 2,500 meters is an unfavorable condition for the mosquitoes are not found. Okay, when the altitude is increased, the oxygenation decreases, so obviously the mosquitoes will not have enough oxygen to survive, so they are said to be an unfavorable condition, and the mosquitoes are usually not found. And then we will move further to the man-made setups like the burrow pits, garden pools, irrigation channels, and engineering projects like construction. They have led to be a breeding of mosquitoes and an increase in the malaria. Can you see here in the seasons, it is again to the rainfall season. And then the rainfalls are providing opportunity. In the humidity, 60% humidity is necessary for the mosquitoes to live. And altitude, high altitude areas, the mosquitoes do not survive. And the man-made setups like burrows, garden pool, burrow pit, and irrigation channel. You can think about the fields. We have irrigation channels. The irrigation channels and engineering projects like constructions are leading to the breeding of mosquitoes and an increase in the malaria. Then we will see the temperature. Optimum temperature for the development of malarial parasite in the insect vector is between 20 to 30 degrees. The parasite ceases to undergo development if the temperature is below 16 degrees. The optimum temperature is 20 to 30, and it stops growing. The development of the parasite inside the mosquito ceases if the temperature falls below 16 degrees Celsius. Is it clear? So in the environmental factors, you know very well, you're going to mention about the season. In the season, you can write from the July to November, there is an increased incidence. Then you can write about the humidity to 60%. and the temperature, the favorable temperature is 20 to 30 degrees, and it stops growing. The cycle stops, and it stops the development under the temperature of 16 degrees Celsius. And the altitude, high altitudes, okay, humidity, season, temperature, and altitude. The high altitude of 20,000 to 2,500 meters or higher will become unfavorable for the mosquitoes to grow. Is it clear? Then we will come to the mode of transmission. The mode of transmission will include the vector transmission, direct transmission, and congenital transmission. Is it clear? What are the various things we see? We have the vector transmission, direct transmission, and congenital transmission. In the vector transmission, the malaria is transmitted by the bite of the certain species of infected female Anopheles mosquito. It is very simple. Vector transmission, obviously, by the term vector only, you can tell it that it is caused by the female Anopheles mosquito. Okay, female Anopheles mosquito. And comes the direct transmission. The direct transmission, it may be induced accidentally by the hypodermic, intramuscular, or intravenous injections of blood or plasma, example during the blood transfusion. And malaria in the drug addicts. Blood transfusion also poses a problem because the parasite keep their infective activity for at least 14 days in the blood bottles which are stored. Okay, so person who has lived in endemic areas, who have been taking anti-malarials, and anyone who had malaria should not be accepted as a blood donor until 3 years afterwards. Are you understanding? Accidentally by hypodermic, IM, and IV blood or plasma. Along with that, we understood that the person who have been had malaria in the past and up to 3 years, he should not donate the blood because the parasite remains to live. Okay, the parasite remains to live in the bottles. Then we have congenital transmission. The congenital infection of the newborn from an infected mother may also occur, but it is comparatively rare. But there are certain instances where the newborn will get the infection from the mother. Then comes the incubation period. What is incubation period? It is the length of time between the infective mosquito bite and the first appearance of signs. What is incubation period? It is the time. It is the time between the clinical signs and symptoms to appear, and the bite of the mosquito. Is it clear? This is the bite of infected Anopheles mosquito, bite of infected mosquito, and the time taken to show the signs and symptoms. In cases of Plasmodium falciparum, the falciparum will show signs and symptoms within 9 to 14 days, and the vivax from 8 to 17 days, P. ovale from 16 to 18 days, P. malariae from 18 to 40 days. Is it clear? 9 to 14, 8 to 17, 16 to 18, okay, and then we have 18 to 40. And the order: falciparum, vivax, ovale, and malariae. Is it clear? Next, we will move further to the life cycle of malaria parasite. This is very important so that we can correlate with the clinical features. We will try to understand it beautifully with the pictures given here. Okay, the life cycle of malarial parasite. First, we will discuss about the mosquito and then the humans. How the cycle happens inside the mosquito and then in the humans. Malaria is caused by the Plasmodium species. So we'll just write down here the malaria which is caused by the Plasmodium species. In the Plasmodium species, we have Plasmodium falciparum, vivax, ovale, and malariae. So these Plasmodium falciparum vivax ovale and malariae requires two hosts to complete its life cycle. So the mosquito will be one host, the female. What mosquito? The female mosquito. What is the name of this female mosquito? Anopheles mosquito. Female Anopheles mosquito, which will be the definitive host, and the humans will be the intermediate host. Okay, they are the intermediate host. Now let us see the infective stage to humans and the erythrocytic stage of malaria, which is the blood stage, and we will further see what it causes. Now let us begin with the infective stage to humans. When an infected female Anopheles mosquito is biting a human, it is injecting sporozoites. Okay, it is injecting sporozoites into the bloodstream, and then comes the liver stage. So first, what was that? Infective stage. First stage is infective stage. In infective stage, what happened? The female Anopheles mosquito bit the human, and after the bite of the human, it released the sporozoites. So the infective stage. Then comes the liver stage. Second, we have liver stage. Let me just clear it to you. Yeah. First, infective stage, where the mosquito Anopheles bites the human and releases sporozoites. And second comes the liver stage. In the liver stage, it is also known as pre-erythrocytic stage. The sporozoites will travel into the liver. They will start invading the liver cells. You can see they are invading the liver cells. And after invading the liver cells, they start to multiply asexually. Here, they are just multiplying. They are just multiplying asexually. Multiplying asexually to form schizons. So, they are forming what? They are forming the schizons. The schizons are going to rupture and get released as merozoites into the bloodstream. Is it clear? So what happened? In the liver, they multiplied asexually to form the schizons. Okay, they form the schizons, and these schizons are rupturing and releasing the merozoites. Okay, they are releasing merozoites into the bloodstream. Is it clear? Did you understand the liver stage? Infective stage, mosquito bit, and then these sporozoites will enter into the liver cells, that is hepatocytes. They will multiply asexually inside the liver cells, that is inside the hepatocytes. They are multiplying asexually, and they form the schizons, and these schizons are going to rupture and get released as merozoites into the bloodstream. Is it clear? Now we understood the liver stage. So here you can see in the liver stage, the P vivax, P ovale, these parasites sometimes will remain dormant in the liver cells as hypnozoites. These can cause the relapse of the infection later on. Okay, that's somewhere in the corner you have to remember that P ovale or P vivax sometimes do not enter into the next stage. They will remain dormant there only without rupturing, and they are known as hypnozoites, and sometimes when they rupture in the future, they can cause the infection. Now let's see what happens next. Then comes the erythrocytic stage of the malaria. Okay, so far I hope it is clear. Now we will move further to the erythrocytic stage of the malaria. You can see we are entering the erythrocytic stage of the malaria, which is also known as the blood stage. Okay, erythrocytic stage, blood stage. One was infective stage, two was liver stage, and then we will see the blood stage, that is the erythropoietic stage. In this erythrocytic stage, after completing the development in the liver, the malarial parasite now has entered the bloodstream and it is infecting the red blood cells. and this stage is responsible for the clinical symptoms of malaria. So we see that the merozoites which have been entered into the bloodstream, they will invade the red blood cells. Is it clear? These merozoites are invading the red blood cells. Okay, the merozoites are invading the red blood cells, and after entering the red blood cells, each merozoite will enter a RBC, and it starts to begin to grow and develop inside the RBC, and the parasite passes three stages. Inside the RBC, it passes three stages. The first stage is the ring stage. It is also known as early trophozoite stage. It is also known as early trophozoite stage. It is the ring stage. The parasite appears like a ring shape under the microscope. Why is it called as a ring stage? Because under the microscope, when you draw the blood and observe the RBCs, this parasite inside the RBC will appear as a ring. So it is known as ring stage. It feeds upon the hemoglobin inside the RBC. This is the earliest blood stage and it is important for the diagnosis. Okay, this is the earliest blood stage. Then comes the mature trophozoite. You can see from the ring stage it is turning into a mature trophozoite. The parasite has started to grow larger. It digests the hemoglobin. So the parasite is growing larger, and after growing larger it is also simultaneously digesting all the hemoglobin. It is feeding on the hemoglobin. The RBC now has become all weak and damaged. And then comes the schizont. The parasite divides repeatedly. Again, the division is occurring inside the RBC. The parasite is dividing inside the RBC repeatedly, and it is forming new merozoites. So it is forming new merozoites. The RBC is now packed with the parasites. You can see now it is forming new merozoites and it is packed with the parasites. Then comes the rupture of the RBCs. Once the RBCs will rupture, the merozoites are again released into the bloodstream. And at this time, the toxic substances are released at the same time, and this is causing the fever, chill, sweating, and anemia occurs because of the destruction of RBC. And the repeat of the cycle occurs. These merozoites gets released and they go and infect new RBCs. Is it clear? I hope you've understood. Then comes the formation of gametes. What happens? Some merozoites do not continue to grow. In fact, they will start mating with each other, and we have some merozoites. They do not undergo the asexual multiplication. Instead, they will undergo a sexual phase where there is male and female gametocytes, and these gametocytes will start, they turn into male and female gametocytes, and these gametocytes keep circulating in the blood. And now when the second time another fresh mosquito, female Anopheles mosquito bites this person, it injects these gametocytes, continuing its life cycle in the mosquito. Okay, then we will go into the mosquito. For now, let us quickly revise what we studied. I hope it is clear. First, we saw the infective stage. In the infective stage, this mosquito is releasing the sporozoites. The sporozoites will enter into the liver, and once they enter into the liver, they will attack the hepatocytes. And in the hepatocytes, they will start multiplying, and the sporozoites will form a schizont. Okay, in the liver, they will form a schizont, and these schizonts will rupture and they will release merozoites, and these merozoites will enter into the bloodstream, and after entering the bloodstream they will affect the RBC. In the RBC they will form a ring stage. Once they grow, they form a ring stage. Why ring stage? Because they appear as a ring under the microscope. Then once they grow, they turn into a trophozoite. These trophozoite, as they start multiplying and becoming mature, they eat off the HB, they feed on the hemoglobin, and the RBC becomes totally weak once the parasite is loaded in the RBC. And you see, then the trophozoite, after multiplication and becoming large, it turns into a schizont, and these schizonts again, when they rupture, in each stage it's the same: sporozoite entering, forming schizons rupture, release merozoites. Again here RBC ring stage trophozoite schizon rupture and release merozoites. And again these trophos from the ring stage it forms a primary trophozoite, mature trophozoite, and then a schizon. So many of these schizons, the parasite is dividing repeatedly inside the RBC forming merozoites. And now when the RBC is packed with the parasite, it ruptures, releases the merozoites into the bloodstream, and these few merozoites will start converting into gametocytes. They do not multiply asexually, instead they turn into a gametocyte. Is it clear? And these gametocytes are circulating in the blood, and now this mosquito has feeded on these gametocytes. Okay, once the mosquito bites the person, it is injecting these gametocytes, continuing its life cycle. So let's see what happens. Now this mosquito has taken up these gametocytes. Okay, these gametocytes, what happens in the infective stage of mosquito, another mosquito has bitten this infected person, it has ingested these gametocytes. Then what happens inside this mosquito? The sexual cycle occurs. The sexual cycle, in the sexual cycle is also known as sporogony. Okay, the sexual cycle, yeah. Then inside this gametocytes, the sexual cycle takes place. The sexual cycle is also known as sporogony. In the mosquito's gut, these gametocytes, okay, now it is entering the gut of the mosquito, and these gametocytes will develop into male and female gametes. Okay, they are getting converted into male and female gametes. The fertilization occurs, and these gametes, male and female gametes, will fertilize. Okay, fertilization, the fertilization of the male and female gamete occurs, leading to zygote formation. Okay, leading to a zygote formation, and this zygote becomes a ookinete, and ookinete which will penetrate the gut wall, and it turns into a oocyst. Okay, it penetrating the gut wall, it is turning into a oocyst. Oocyst is rupturing, and it is releasing these sporozoites. They will migrate into the salivary glands. Okay, they are migrating into the salivary glands of this mosquito, and the cycle repeats. Now it makes sense how the sporozoites were present in the mosquito. Is it clear? Let me just quickly summarize it to you. Fresh one mosquito bit a human, sporozoite, infective stage, then comes liver stage, then comes RBC stage, and the gametocytes are released. When this mosquito, second mosquito, has bitten the infected human, it has sucked the blood which is containing these gametocytes, and once the gametocytes enter into the gut of the mosquito, the fertilization takes place. It gets converted into zygotes gets converted into ookinete, and the ookinete is further developing into oocyst. Okay, it develops into oocyst, and after the development into oocyst, it ruptures. Rupturing releases sporozoites. Is it clear? And when this mosquito again bites another person, sporozoites release, and the same cycle continues. I hope it is clear. Okay. Next, we will see quickly the life cycle of malarial parasite. Transmission to human. It injects the sporozoite via the bite. They will enter the liver, infect the hepatocytes. Mitotic replication. Okay, asexual multiplication occurs, and the liver cells will rupture, release the merozoites. These merozoites will undergo a sexual cycle, and they will produce gametocytes inside the RBC, and then the transmission to the mosquito. This mosquito will inject the gametocytes. The gametocytes are mating, and they are forming a zygote, and the zygote will develop into a ookinete into a oocyst will rupture, sporozoites are developed, and these sporozoites are again reaching the salivary gland. Okay, salivary gland of the mosquito. I hope it is clear. I've just given you a summary. Okay, Next, we'll see the pathophysiology. The pathophysiology is nothing but the life cycle of the malarial parasite and the malarial parasite symptoms, how they show up. We have to discuss. The malarial life cycle is a complex system in which both sexual or asexual aspects will take place. In all the species of the plasmodium, they will infect the humans. It is basically the same even in plasmodium vivax, in the plasmodium vivax, in the plasmodium ovale, in the plasmodium falciparum, and in also in the plasmodium malariae. It is all the same. And then there is an exogenous sexual phase in the mosquito, as we discussed. In the gut, the gamete, zygote, ookinete. So the sexual phase in the mosquito, it is known as sporogony, during which the parasite is multiplying. It is known as sporogony. And there is an endogenous asexual phase which is taking place in the vertebrate or the human host. This is known as schizogony. Okay, in the liver, the sexual multiplication in the RBCs, this is known as schizogeny. Okay, that is sporogony. This is sporogony. This is schizogeny. Is it clear? Next, we will move further to the symptoms of malaria. Malaria symptoms mainly occur because of the destruction of red blood cells, release of toxins. You know very well, the pathophysiology is super clear to us. So, this pathophysiology is going to help us a lot in understanding why these symptoms come up in the patient. Okay, I want you to have the concepts very clear. Next time anybody speaks about malaria, you should have a clear cut understanding why the patient presents. Now, the dengue, how beautifully we understood what is the pathophysiology, what actually is happening inside the body in the previous session. Now, let us see malaria in detail. Why the patient presents with these symptoms and how can we relate with the pathophysiology? So, mainly the RBC's damage, the destruction or damage of RBC, release of toxins. Okay, along with the rupture of RBC, there is a release of toxins, and the basic immune response. Okay, the immune response of the person will be responsible for the symptoms. So, let us see fever. First, we have systemic symptom, that is fever. The fever can present in an intermittent fever or a periodic fever. It occurs because of the rupture of infected RBC. When the lots of merozoites are released into the bloodstream, it is also releasing toxins which are triggering the cytokine release. We have the cytokine release like tumor necrosis factor alpha, interleukin 1. So these are causing the chills, fever, and sweating. Okay, and in the skin we have chills and sweating. This is caused by the sudden cytokine release. Let me just write it down for you here. So what happens first? There is a release of merozoites. The release of merozoites plus toxins, and this triggers the immune system. It triggers immune system, and the triggering of the immune system releases a lot of immune system. It releases cytokines, and these cytokines will include the tumor necrosis factor alpha, interleukin 6, etc. So we see that the skin, in the skin, the chills and rigors, they are caused by the sudden cytokine release which is affecting the hypothalamic temperature center. And this will be the first noticeable symptoms. So we discussed about fever, chills, and sweating. Then we will see about the profuse sweating which is seen. It occurs when the fever is breaking. So the body is trying or attempting to reduce the elevated temperature in the form of sweating. So it's just a response by the body that in order to reduce down the temperature, it is reduced in the form of sweating. And we have headache. The next symptom in the central, we have headache due to fever, the cytokine release, and the cerebral vasodilation. Because of the cerebral vasodilation, the headache is seen. Okay, and then we have anemia. Also, anemia is seen because of the destruction of red blood cells. You can also write down one of the symptoms as anemia. And the suppression of bone marrow also occurs. The patient will be very fatigued, will have muscular pain, and we have weakness, back pain, muscular pain, fatigue, and it is all occurring as a result of anemia. Okay, you can remember anemia. In anemia, the patient has back pain, fatigue, muscular pain, etc. And there is a reduced oxygen supply to the muscles, so that can also lead to pain and fatigue. And then comes the spleen enlargement. Spleen enlarges because of the increased rbc destruction and immune activity which is taking place. Okay, the spleen enlargement is seen. And we have the nausea, vomiting, and diarrhea. So these nausea, vomiting, and diarrhea can also be seen due to the toxins release and the systemic inflammatory response. The muscle pain, joint pain because of the cytokine mediated inflammation, and the respiratory dry cough can also be seen. Is it clear? Can you remember it now? Let's just recall everything. We have in the head headache, fever, systemic fever, muscular pain, fatigue, back pain. Stomach, there is nausea and vomiting. In the spleen, enlargement of the spleen. Respiratory, there can be dry cough. And in the skin, you can remember the chills and sweating. Is it clear? Now let's see how malaria presents clinically. In the stage 1, the patient can have chills for 15 minutes to 1 hour. It can occur because of the rupture from the host red cells which will escape into the blood. It will present with nausea, vomiting, and headache. Is it clear? In the stage 1, we have chills. The chills occur because of the rupture of the red cells. And the patient can also present with nausea, vomiting, headache. Then comes the stage 2. The fever will reach up to 40 degrees Celsius and it can last up to several hours because the new red blood cells are getting affected. Then comes the stage 3. The patient starts sweating, concluding the episode of the fever. The cycles are frequently asynchronous. Paroxysms will keep occurring every 48 to 72 hours because when the rupture of the RBC occurs, lots of merozoites are released into the bloodstream, and these merocytes are going to affect a new group of red blood cells. And when the fresh red blood cells are released and they rupture and toxins are released into the bloodstream, there is a fresh episode of fever every 48 to 72 hours. In Plasmodium malariae, pyrexia may last for 8 hours or more and temporarily exceeds 41 degrees Celsius. Okay, in Plasmodium malariae. Okay, in Plasmodium malariae, the pyrexia is a medical term for fever. It lasts for 8 hours or more than that. Then we will move further to the differential diagnosis. In the differential diagnosis, you can think of the upper respiratory tract infections, pharyngitis, tonsillitis, ear infection. You can correlate here with the, with the symptoms. Here the patient presents with the dry cough, fever, body pain, and nausea and vomiting. So on the upper respiratory tract infections you can think of, because the differential diagnosis is considered upper respiratory tract because the patient can present with fever, body pain, and chills and throat pain. Then comes pneumonia. In pneumonia, you can think that again you can correlate with the fever, chills, and everything. And we have measles. We also have dengue, influenza, typhoid fever. So let us see about the dengue fever. Dengue fever, the patient will have high continuous fever. The patient can present with high continuous fever, severe body pain, retroorbital pain. You can think of the retroorbital pain in cases of dengue. And in dengue, thrombocytopenia is more marked. Okay, the platelet count is affected. Thrombocytopenia, the platelet count is decreased. Thrombocytopenia is more marked. No periodic fever pattern, and the peripheral smear will be negative for malarial parasite in cases of dengue. Then comes the typhoid fever. In the typhoid fever, you can think of the step ladder pattern of the fever. Okay, it is the step ladder pattern. You can think of the step ladder pattern of the fever. And in typhoid fever, most commonly the GI symptoms like constipation, abdominal pain, diarrhea also occurs. And in the typhoid fever, apart from the step ladder pattern, you can also think of the Vidal test being positive. Okay, the Vidal test will turn out to be positive in cases of typhoid. And the chills and rigor will be comparatively less. Okay, no chills and rigors. Then we have viral fevers. Okay, the viral fevers, they have short duration, and the fever will be very mild in these cases. Okay, mild fever is seen. No splenomegaly. There will be no splenomegaly. There will be no signs of anemia. Anemia will not be found. HB won't be affected much. There's no anemia. Splenomegaly is not found, and it is self-limiting. Then you can also add on chikungunya. Okay, the other differential diagnosis. You can think of chicken. Just a second. Let me start. Give a fresh page to the other differential diagnosis. Additional, you can think of chikungunya. In chikungunya, we see that the along with the high fever, severe high fever, patient will have lots of joint pains. Okay, joint pains will be there, and these joint pains will last for weeks together. There will be no periodic fever. Then you can think of leptospirosis. Leptospirosis, the patient will have the jaundice, myalgia. Okay, and there will be history of exposure to the contaminated water with the urine of the infected rats. And then we have renal involvement also will be seen in leptospirosis. Then we have kala azar. Okay, Kala azar. Kala azar is also known as visceral leishmaniasis, right? Yeah, Kala azar is also known as visceral leishmaniasis, where the fever will be prolonged and the splenomegaly will be massive. Here, in this case, there will be massive splenomegaly, weight loss, dark skin, etc. Kala azar, splenomegaly, and we have dark skin. Then we have the septicemia. Another thing we can think of is septicemia. In septicemia, there will be continuous fever. The patient will have a toxic appearance. Okay, the toxic appearance is seen in the patient, and the positive blood culture, there is no cyclic fever pattern. Okay, so we can suspect malaria in a patient who is having fever, chills, but the confirmation will require the demonstration of parasite in the peripheral blood. Now we'll move further to the complications. In the complications, the three main complications you can remember is the cerebral malaria, severe anemia, and renal failure. The others will include a lot. So we'll first discuss in detail about each of them. We have main importantly the cerebral malaria, severe anemia, renal failure. Let's start discussing about the cerebral malaria. Yeah, the cerebral malaria may begin slowly or it can also occur suddenly. In cerebral malaria, the patient will have altered consciousness. The patient can present with altered. These are the complications of malaria. The patient can have altered consciousness, seizures, or coma. Okay, seizures and coma. This is caused by the sequestration of infected RBCs in the brain capillaries. These infected RBCs are getting sequestrized in the capillaries of the brain, that is leading to altered consciousness, seizures, and coma. Here they are saying this a patient having a complication of cerebral malaria with may have a high fatality rate up to 20%. With the successful treatment, complete recovery can be obtained, and the permanent disablement rarely occurs. Okay, the permanent disability will be rarely seen. There can be complete recovery with the successful treatment. Okay, altered consciousness, seizures, and the coma will be the presentation. And why does it occur? Because of the sequestration of infected RBCs in the blood capillaries. Because of this repeated hemolysis of RBCs and the bone marrow suppression, the patient can also have the anemia that is commonly present in the children, and you can see anemia in the pregnant women also. And then we'll see what happens further. We have inevitable consequences of severe infection. It can be fatal unless a blood transfusion is given. It can be fatal. Okay, the HB can fall too low and it might require a blood transfusion. Unless this transfusion is given, it can turn out to be fatal. Then comes the renal outcome. In the renal outcome, we see that it is patient is presenting with dwindling urine output. Okay, there is oliguria, or there can also be anuria. It is because these inflammatory cytokines, the parasite toxins, they are stimulating these cytokine release. We know that the toxins, the parasites and the toxins, they are releasing the cytokines. They are causing the release of cytokines, and these cytokines are causing the endothelial damage and worsening the renal function. And the patient presents with oliguria, anuria, the serum creatinine urea will be increased. The serum creatinine is increased, urea is increased, and the patient can have a dark colored urine, fluid imbalance, electrolyte imbalance, because it is dangerous, because the patient can rapidly progress to uremia, and the patient can land up even into dialysis. So it has a high mortality if it is untreated. Hypoglycemia in malaria can also occur. And then we see the continuous rehydration is effective in most cases. Peritoneal dialysis sometimes may be needed. It has a bad prognosis. Is it clear? And along with that, we have the HB is being filtered by the kidneys, and these HB hemoglobin is filtered by kidneys, and that damages the renal tubules, causing the acute tubular necrosis, and the microvascular obstruction is also seen. Because these RBCs are filled with the parasites, they are going to adhere to the renal endothelium, and once they adhere to the renal endothelium, they are causing the impaired filtration, and there is dehydration, hypovolemia because there is increased sweating, vomiting, fluid loss occurs. So the circulating volume is decreasing, reducing the renal perfusion, worsening the kidney injury. Is it clear how it is happening inside? The toxins are causing a damage to the endothelium, and along with the endothelium, it is causing the cytokine release, affecting the glomerular filtration rate, and the loss of fluid is leading to dehydration and hypovolemia. And it is causing the increase in the serum creatinine and urea levels, dark colored urine, oliguria, anuria. The others, we have hepatic dysfunction, and you can think of hypoglycemia. Why hypoglycemia occurs? Because the parasite is consuming the glucose. The parasite is living inside the liver and inside the RBCs, and it is depending entirely upon the glucose for its energy. In severe malaria, there is a high parasite load, and it is consuming lots of glucose inside this. Okay, lots of glucose is being consumed by this malarial parasite, and it is leading to hypoglycemia. And shock can occur, pulmonary edema. So you can think about the pulmonary edema. The hypovolemia can also lead to shock. Then comes the pulmonary edema. What happens is, again, the sequestration of infected RBCs is seen, and the pulmonary edema is a life threatening complication which is occurring in the malaria because of the sequestration of infected RBCs, and these infected RBCs is adhering to the pulmonary capillaries and endothelium. Okay, they are adhering to the endothelium, the pulmonary capillaries of the endothelium, and these are causing the microvascular obstruction in lung capillaries. Okay, the microvascular obstruction, the blood vessels are being damaged, it is causing obstruction in lung capillaries, increased capillary permeability. So these parasites are also triggering the release of inflammatory cytokines. They are damaging the capillary endothelium, and the fluid accumulation occurs. So the non-cardiogenic pulmonary edema is seen. Is it clear? Everywhere it is going and damaging the endothelium. It is causing the microvascular obstruction. In the kidneys, it causes the decrease in the glomerular filtration rate. In the lungs, it is damaging the capillaries, and it is causing the fluid escape into the interstitium, and the patient can present with breathlessness, and we saw the pulmonary edema, and it leads to hypoxia, severe breathlessness, rapid breathing, cough, etc. Okay, and then we will see, if it is not treated promptly, it might require the ICU care, ventilatory support, etc. Is it clear? And the fluid electrolyte imbalance because of the vomiting, and vomiting and diarrhea is seen because of the inflammatory effect, the cytokine release irritating the mucosa of the stomach and leading to vomiting and diarrhea. And we have secondary bacterial infection because of the HB low, anemia, and reduced immunity. The patient is more prone to secondary bacterial infections, bleeding disorders, clotting disorders, and hemoglobinuria and black water fever. So the patient will have the black water fever, and he can also have the hemoglobinuria. I hope it is clear. The complications we have discussed in detail. Now we will move further to the diagnosis. In the diagnosis, we have microscopy. Two types of blood films are useful in searching and identifying. We have the thin film and the thick film. So the peripheral blood smear, the peripheral blood smear is of two types. Okay, two types. We have thin blood film and a thick blood film. Thin blood smear is, the blood is spread in a thin layer. Okay, here the blood is spread in a thin layer. RBC morphology will be preserved. It helps in identifying the species. We can see the ring stage of the RBC, and we can see the trophozoites, schizons, gametocytes, etc. Okay, we can see the trophozoites, schizons, and we can think about the gametocytes appearing in the film. And then comes the thick blood smear. In the thick blood smear, the blood is spread thickly. Okay, we are spreading the blood thickly. RBCs are lysed during the staining, and the parasite has become very concentrated. Then this becomes more sensitive, and it is best for detecting low parasitemia. And the stain we use is Jimsa stain, which is commonly used. Okay, and then we have the thick slide is more valuable for identifying the species if the parasite is present. And then we have the thick film being more reliable in searching for the parasite. A large volume of the blood is examined under each microscopic field. The advantages of this thick film, its sensitivity will be high. It is possible to detect the parasite at a low density. It is also possible to distinguish between the various species of malarial parasite, vivax, oval, falciparum, malaria, and their different stages, whether they are in a merozoites, or they are in the schizon stage, or in the ring stage. Okay, and then we will move further. Along with the peripheral smear, thick and thin film is done. Now we will see the serological test. The serological test will detect the antibodies or the antigens which are related to the plasmodium. The serological tests are going to detect the antigens and antibodies. They are detecting the antigens and antibodies which are related to the plasmodium. They are mainly used for supportive diagnosis, for screening, and not for the routine confirmation. We are just using it for a supportive diagnosis. And in that, we have antibody detection test, and we have the common one which will detect the IgG, IgM in the blood. We have malarial fluorescent antibody test. Okay, that is ELISA. Under ELISA we have the malarial fluorescent antibody test, indirect fluorescent antibody test. They are usually positive 2 weeks after the infection, and it will also indicate the past exposure to malaria. It is useful in cases of epidemiological surveys. Then this test is of a great value, especially in the epidemiological studies and determining whether the patient had malaria in the past. So what did you understand? The serological test is useful in cases of epidemiological studies and to determine whether the person had infection in the past. Then we will discuss about the rapid diagnostic test. The screening of the blood, the donor's antigen detecting test. Okay, the RDTs, rapid diagnostic test, is based on the detection of circulating the antigens with a simple dipstick format. So we have a simple dipstick format for detecting the circulating parasites. Several types of RDTs are available. I hope it is clear. Next, we will move further to the measurement of malaria. In the measurement of malaria, we have pre-eradication era. Okay, in the pre-eradication era, the magnitude of malaria problem in a country used to be determined from the reports of the clinically diagnosed malaria cases. How we are measuring how the magnitude of malaria is determined by the reports. Okay, by the reports of a person. It can be the rapid diagnostic test, or we can have the fluorescent test, ELISA, or we can think about the other test, that is the peripheral smear. We can think of serological test and peripheral smear. Okay, so these reports of the clinically diagnosed malaria cases were used as a magnitude for measuring the malaria cases in the pre-eradication era. The classical malariometric measures will include the first one is the spleen rate. It determines the it is defined as the percentage of the children below between 2 and 10 years of age showing the enlargement of the spleen. So we are seeing the children between the age of 2 years to the children of the age 10 years, 2 years to 10 years, showing the enlargement of the spleen. This spleen rate is widely used for measuring the endemicity of malaria in a community. So we are measuring the endemicity of the malaria in a community. And now we'll see the average enlarged spleen. This is further refinement of the spleen rate. Okay, the average of the enlarged spleen. We are refining the spleen rate, denoting the average size of the enlarged spleen. Okay, the average size of this enlarged spleen has been determined. And next we will see the parasite rate. It is defined as the percentage of the children between the age of 2 years to the age of 10 years showing malaria parasite in their blood film, which is nothing but we are measuring the films. Again, the diagnostic test in the pre-eradication area also we are measuring the spleen rate, how much splenomegaly is seen, at what centimeter the spleen has been enlarged between the age of 2 years to 10 years, and how many children are showing the positive malaria parasite in their blood films. And the parasite density index, it is the average degree of parasitemia in a sample of well defined group of population. So we are seeing what is the degree of parasitemia. It is nothing but the parasite in the blood, parasitemia. So we will we'll see in a sample of a group of population what is the degree of parasitemia found. And then the infant parasite rate, it is defined as the percentage of infants below the age of 1 year showing the malarial parasite in their blood test. Obviously infants are those who are below the age of 1 year, and we are measuring the parasite rate. So we are going to see in how many infants are showing the malarial parasite in their blood test. It is regarded as the most sensitive index of recent transmission of malaria in a locality. So this will become the most sensitive index of the recent transmission. Next, we will come into the eradication era. The microscopic diagnosis of malaria cases has become a main method of diagnosis. So, in the eradication era, in the pre eradication era, they were using the spleen rate. Okay, in the pre-eradication era, the measures of malaria in the pre-eradication era, they used to measure the spleen rate, the average enlarged spleen, the size of the averaged enlarged spleen, and they are also going to see the parasite rate, the parasites rate, and parasite density index. Okay, parasite density index, infant parasite rate. Okay, infant parasite rate. How can you remember this? First, spleen rate, enlarged spleen, average enlarged spleen. 2 points are clear to remember. Parasite rate, infant parasite rate, parasite rate, infant parasite rate. Then we have parasite density index. I hope it is clear. Then comes in the eradication era, we are using the microscopic diagnosis of malarial cases as a main method of diagnosis. The following parameters are used for the measurement of malaria, were most parasitological in nature. What were the parasitological measures? We have annual parasite index, annual parasite index. Annual parasite index, how can we measure? The formula is the cases confirmed during 1 year. Annual is 1 year. Okay, annual is 1 year. The cases confirmed during 1 year. Annual parasite index, so we are seeing the entire population which is under the surveillance into 100. Okay, it is the cases confirmed annually by the population under surveillance into 100. And then we have annual blood examination rate. Okay, then we have annual blood examination rate. In the eradication era, we perform the annual blood examination rate. Blood examination, so we have the number of slides examined. Blood examination is the number of slides examined by the population into 100. Then we have the annual falciparum index incidence. So we are seeing the emergence of Plasmodium falciparum in India. Data are collected separately for the total malarial cases and the Plasmodium falciparum cases. So we are seeing the incidence of the malarial falciparum. Okay, Plasmodium falciparum cases. So we are measuring the total number of cases and the Plasmodium falciparum cases. We are collecting the data separately. We are collecting the data to see how many are malaria caused by Plasmodium falciparum, and the remaining 3 are collected separately. That is ovale, vivax, and malaria. Then slide positivity. It is the percentage of slides found positive for malaria parasite irrespective of the type of species. We are not going in detail about the Plasmodium ovale or vivax or malariae. We are just counting the percentage of slides which are positive for the malaria parasite. And the slide falciparum in rate, it is the percentage of the slides which are positive for falciparum parasite. So in the first thing, we are seeing the collecting the data separately for the P. falciparum cases, and we are also measuring the percentage of the slides positive for Plasmodium falciparum parasite. I hope it is clear. okay, the annual parasite index, and we saw the annual blood examination rate, and we will also see the blood slides with the percentage of slides, okay, the percentage of slides which are positive for falciparum cases, and we will also see the separately collect the data for the plasmodium falciparum cases, okay. This is in the eradication era. And then we will move further to the vector indices. A malarial survey is not complete unless it is including the investigation which is related to the insect vector. Some of the important vector indices will include human blood index, sporozoite rate, mosquitoes density, man biting rate, and inoculation rate. In the human blood index, it is seen that the proportion of freshly fed female Anopheles mosquito whose stomach is containing the human blood, it indicates the degree of anthrophilism. Okay, we are seeing the proportion of freshly fed female Anopheles mosquitoes gut which is containing the human blood. And we have sporozoite rate, it is a percentage of female Anopheles sporozoites in the salivary gland. And in the mosquito density we can see the number of mosquitoes per human hear catch. And then we have man biting rate. In the man biting rate you can see the average incidence of mosquitoes which are biting a man per day. And we will also see the it is har, okay, this is har, it's just an error, man har catch, okay, it is expressed as the number of mosquitoes per man's har catch, okay, per hour how much the each man is catching the mosquitoes per hour catch, okay. That is how we are going to measure the mosquitoes density. Then we have the man biting rate, average incidence of mosquitoes biting a man per day. Inoculation rate, the man biting rate multiplied by the infective sporozoite rate, it is the inoculation rate. What is inoculation rate? The man biting rate is multiplied with infective sporozoite rate, okay. We have measured the sporozoite rate, right? It is the percentage of female Anopheles sporozoites in the salivary glands of the mosquito. And we measured the mosquito's density, human blood index, how much freshly fed female Anopheles mosquitoes were containing human blood, in how many mosquitoes salivary glands the percentage of female Anopheles having sporozoites, and the mosquito's density based upon per man har catch. And then we have man biting rate and inoculation rate. We are multiplying the man biting rate with the sporozoite rate. I hope it is clear, the vector indices. Then we are moving further to the approaches and the strategies of malaria control. The strategic action plan for malaria control in India took place in the year 2007 to 2012. In the year 2012 to 17, and more recently, the malarial control in India was started in the year 2017 up 2022, and it was developed by the Directorate of National Vector-Borne Disease Control Program. National Vector-Borne Disease Control Program, NVB-DCP. Okay, who started the approach for the malaria control? NVB-DCP program, disease control program. It was developed by the Directorate. Okay, this program was developed by the Directorate of NVB-DCP program. He started the malaria control. Okay, he started the malaria control. The strategic action plan, he started the strategic action plan for malaria control. And it was up recent year was 2022 to, okay, 17 to 22. What were the strategies for malaria control? 1. Surveillance and case management, that is case detection. It can be the passive cases and active cases, early diagnosis and complete treatment, sentinel surveillance. Okay, these were the surveillance and case management. Surveillance, sentinel surveillance. In the case management, case detection and diagnosis and complete treatment. Is it clear? In the surveillance, what you can remember, case detection and sentinel surveillance. And we have early diagnosis and complete treatment. Then comes integrated vector management. In the integrated vector management, we have the indoor residual spray and the insecticide treated by bed net, long lasting insecticidal nets, anti larval measures which are including the source reduction. So we can see that in the vector management, the female anopheles mosquito has to be prevented from spreading the infection or the killing of this female anopheles mosquito. How can we do that? By the residual spraying, by insecticide, using the insecticide treated bed net, long lasting insecticidal nets, anti larval measures, etc. Then comes epidemic preparedness and early response. We have supportive interventions. In the supportive interventions, we have the capacity building. Okay, and the behavioral change communication. We are creating an awareness, we are creating awareness to people regarding the elimination of the burrow pits, and not to have the man-made stagnant water, sources of stagnant water, so that the mosquitoes should stop breeding. So we have to advise and encourage, create awareness to the people regarding the spread of the mosquito anopheles causing the malarial infection, and also causing the intersectorial collaboration. So the health sector will also collaborate with the agriculture. So like this, we are going to collaborate with the different sectors and cause the eradication of malaria. Monitoring and evaluation, very important. We need to evaluate the cases. Constant monitoring is important, and operational research and applied field research is also done. Okay, under the supportive interventions, we have research and applied field research. Next, we have early diagnosis and treatment of malaria. What is the aim for the early diagnosis and treatment? Why do you want to do the early diagnosis and give a complete treatment? So that we can completely cure the person, we can prevent the progression of uncomplicated malaria to the severe disease. Okay, instead of the uncomplicated malaria, if it is not diagnosed at a proper time, if the proper intervention is not done at the required time, then what happens, it will turn into a severe disease causing the cerebral malaria. It can cause the cerebral malaria, then hypoglycemia, shock, reduced renal perfusion, acute renal tubular necrosis, and it can lead to patient can end up into dialysis. Then the patient have respiratory symptoms leading to pulmonary edema. So we saw the various complications, right? So we want to prevent all these complications, so we will diagnose the case early and start the treatment immediately, and also to prevent the death. Then comes the interruption of the transmission. So if the patient is treated, then even if the new mosquito bites him, fresh healthy mosquito, it won't be affected with the gametes. And if the mosquito is not carrying the gamete in its salivary gland, so the next person being bitten by that mosquito won't have the transmission of the disease. If not, this mosquito, once it bites the infected human, it will go and bite various other people, suck its blood, and all these people can be affected, minimizing the risk of selection and spread of drug resistant malaria parasite. Okay, we are minimizing the risk of selection and also the spread of drug resistant parasite. Okay, then comes the vector control. The vector control can be done with the anti-adult measures, that is DDT spraying can be done. And we have the anti-larval measures, larvicidal operations. We are killing the larvae of the mosquito. And then we have the protection against mosquito bites, like using the mosquito nets, mosquito repellents, repellent creams, etc. Then we have the methods of control. The vector control, it is very easy. You can remember the medicated nets, long lasting nets, and we have mosquito repellents, DDT sprays, etc. Okay. Then in the methods of control, removing or poisoning the breeding grounds of mosquitoes. Okay, we are poisoning the breeding grounds of mosquitoes or the aquatic habitats of the larval stages. For example, by applying oil to places with standing water. Okay, by spraying oil, you would have seen a person spraying oil on the surface so that the mosquitoes cannot breed. Spraying the point of breeding grounds or the sources with the DDT, early management and the disease surveillance, monitoring and evaluating the drug and insecticide resistance monitoring. Is it clear? Then we can see we are controlling the spread of the vector with the help of mosquito nets, using insect repellents, closing the windows, and we are reducing the risk of getting bitten. Okay. And then the prevention of malaria, mind before the madness. So what you can remember is the A, B, C and D against the malaria, that we have to spread the awareness. So now by creating this lecture, I am trying to create an awareness against malaria. So, what you can do when you meet somebody or you go up to the rural areas during your posting or your visits, you have to find out the agricultural pits areas where there are burrows and the stagnant water, and there you, as a person in the medical field having the knowledge about malaria, you are responsible now to spread the awareness regarding the malaria and preventing a lot of people being contradicted with that disease. Then the bite prevention. One, spreading awareness, recognizing the malaria, and then comes bite prevention, controlling the mosquitoes with the use of DDT sprays, repellents, etc. Then comes the chemoprophylaxis, using the preventive medications. In the next slide, I will tell you the preventive medications used in the treatment of malaria. And the D stands for the diagnosis, the early recognition and the diagnosis and the proper treatment. Now let's see what is the treatment for the uncomplicated malaria. If the person is affected with Plasmodium vivax cases, chloroquine 25 mg per kg with primaquine 0.25 mg per kg of the body weight is given for 14 days. What are the two things combination? Chloroquine, okay? Chloroquine, primaquine, okay? Primaquine, chloroquine and primaquine. Chloroquine is given at the rate of 25 mg per kg. The dose is 25 mg per kg. Whereas in primaquine, the dose is given 0.25 mg per kg. Is it clear? It is given for the up to 14 days, 2 weeks, okay? And primaquine is contraindicated in G6PD deficient patients, infants and pregnant women. Those who are having G6PD enzyme deficiency, the primaquine is contraindicated in them, because this primaquine in G6PD deficiency patients can lead to hemolysis. Patient should be advised to stop primaquine immediately if he develops symptoms like the dark colored urine, yellow conjunctiva. Okay, you can see in cases of jaundice, there will be yellow conjunctiva, bluish discoloration of lips, abdominal pain, nausea, vomiting. They should report to the doctors immediately. If the patient presents with dark colored urine, yellow conjunctiva, bluish discoloration of lips, abdominal pain, nausea, vomiting, he should report to the doctor immediately, and primaquine should be avoided in these patients. Okay. Next, we will see it is prima only. Okay, it's not PRE, it is PRI. Okay, primaquine. Next, we'll move further for the treatment of Plasmodium falciparum cases. We saw vivax cases, right? The Vivax, just to remember, we'll write it down here. It should not be given in the G6PD deficiency patients. G6PD deficiency should not be given. And we have uh, Plasmodium vivax being treated with chloroquine 25 mg per kg and primaquine. Primaquine is at the dose 0.25 mg per kg for 14 days. Next, we'll see P. falciparum cases. Artemisinin combination therapy. Okay, artemisinin combination therapy, that is artemether lumefantrine for 3 days plus primaquine a single dose on the second day. Is it clear? Artemisinin combination therapy, we have artesunate for 3 days. Let me write down here. Artesunate 3 days plus sulfadoxine pyrimethamine for 1 day, to be given to those who are confirmed with P. falciparum cases and they are found to be positive by microscopy or RDT. Is it clear? Artesunate for 3 days. Along with artesunate, we are going to give sulfadoxine. Okay, sulfadoxine, artesunate. You can take it as, okay, artesunate, sulfadoxine, pyrimethamine. 1 day should be given to those who are confirmed with this cases and positive RDT test. It is also accompanied with single dose of primaquine. Okay, it is combined with a single dose of primaquine and the dose is 0.75 mg per kg on day 2. However, considering the reports to the resistance of this drug in the northern eastern states, and advisory committee now has recommended to use the tablet of artemether lumefantrine as per the age specific dose schedule for treatment of P. falciparum cases in the northeastern states. Okay, so we see that in the northern east, so this artemether lumefantrine tablet, this therapy is used in cases of northeastern states. Okay, northeastern states. Or basically for the P. falciparum, we have two things. The first is artesunate and sulfadoxine pyrimethamine. Is it clear? Artesunate for 3 days, sulfadoxine pyrimethamine for 1 day. It should all be given and accompanied with primaquine, accompanied with primaquine for on day 2. Okay, this is on day 2. So the treatment of malaria in the pregnancy. ACT should be given for the treatment of P. falciparum malaria. ACT, so we have the artesunate lumefantrine tablet, or we have this artesunate sulfadoxine pyrimethamine and primaquine on day 2. ACT should be given for the treatment of P. falciparum malaria in the second and third trimester of pregnancy, while the quinine is recommended in the first trimester. Okay, the quinine is recommended in the first trimester. The ACT should be given in the second and third trimester. ACT stands for artemisinin combination therapy. Okay, artemisinin combination therapy. So the artemisinin, artemisinin combination stands for artesunate, sulfadoxine pyrimethamine and pyroquinine, okay, combination therapy in the second and third trimester, while quinine is recommended in the first trimester. P-Vivax malaria can be treated with, so in the pre-Vivax malaria, they can be treated with chloroquine, and primaquine is contraindicated. As I told you, the artemisinin combination therapy includes only two drugs. What are the two drugs? We have artesunate and sulfadoxine pyrimethamine. Quinine is contraindicated. You saw here, quinine is only given in the first trimester. Quinine is contraindicated in second and third trimester. Only artesunate and sulfadoxyl pyrimethamine can be given. I hope it is clear. Even in the pregnancy, you should be able to tell the artesunate and sulfadoxine pyrimethamine can be given. Quinine is contraindicated, but primaquinine can be given in the first trimester. Then comes the treatment of severe malaria. It is an emergency and the treatment should be given as per the severity and also the associated complications. Before admitting, the rapid diagnostic test should be done and we should take the blood smear. Rapid diagnostic test should be done, the blood smear to be taken, and we should give a parenteral dose of artemisinin derivative and the quinine in suspected cerebral malaria cases. So we can see that the quinine, okay, quinine is given in cases of suspected malaria cases, and along with that ACT, that is artemisinin combination therapy. Okay, we have artemisinin combination therapy. In the artemisinin combination therapy, we have artesunate for 3 days, okay, artesunate for 3 days, and we have sulfadoxyl pyrimethamine, okay, artesunate and pyrimethamine in that sulfadoxyl, okay, sulfadoxin pyrimethamine. So this combination therapy will be given as soon as this test is done. RDT test and blood smear is given as a parenteral dose of artemisinin derivative, or the quinine can also be given in cases of cerebral malaria cases, and we have to send the case sheet, details of treatment history and blood slide with the patient. After the parenteral artemisinin therapy, patient will also receive a full course of area-specific oral ACT for 3 days. So the oral artesunate for 3 days and the sulfadoxine pyrimethamine for 1 day. Patient who have received the parenteral quinine therapy should receive the oral quinine as well. The dose is 10 mg per kg 3 times a day for 7 days, and he is also given doxycycline 3 mg per kg once a day and clindamycin 10 mg per kg for 7 days. Is it clear? The patient who has received the ACT therapy will then be given the quinine, given a full area of OCT for 3 days. After receiving the parenteral quinine therapy, he should also receive the oral quinine. Along with the parenteral quinine, he should also receive the oral drugs. In the oral drugs, we have quinine at 10 mg per kg 3 times a day, TID, okay, 10 mg per kg dose 3 times a day for 7 days, TID for 7 days. Doxycycline, the dose is 3 mg per kg once a day, okay, once a day, or clindamycin 10 mg per kg for again 7 days. Is it clear? Doxycycline is contraindicated in pregnancy. Then we'll see some don'ts in the severe malaria case management. We should not use corticosteroids. Okay, some don'ts. What you have to remember in the treatment of malaria cases, severe malaria cases, it will include don't use corticosteroids. Okay, do not use corticosteroids, and don't give intravenous mannitol. Intravenous mannitol to not be given. Don't use heparin as an anticoagulant because the liver and spleen are already compromised. Don't administer adrenaline, and don't overhydrate the patient. These are the things you have to remember. No steroids, no giving IV mannitol, do not overhydrate the patient, do not administer adrenaline, and don't use heparin as an anticoagulant. Then comes the malarial vaccine. Vaccination against malaria is a burning issue today. Over past decades, there has been a significant progress in the malaria vaccine development. The several vaccine candidates are tested now in Africa, Asia. So, in cases of Africa, Asia, and United States, the vaccines have been started to test. Then comes the chemoprophylaxis. Chemoprophylaxis is recommended for travelers from the non-endemic area as a short-term measure for the soldiers, police, labor force, etc. So we are recommending it for the in the non and patient people who are traveling from the non-endemic areas to the endemic areas. It is it is also used as a short term measure for soldiers, police, and labor force. The recommendations for the short term are dosing schedule for children should be based on the body weight. Okay, as we discussed earlier, we have the artemisinin combination therapy, the artesunate which is given for 3 days, and we have the sulfadoxin pyrimethamine for 1 day. Everything is calculated based upon the dosing. Okay, and we saw in the first the Vivax cases, the doses, the chloroquine at the dose of 25 mg per kg, and we have 0.25 mg per kg as primaquine's dose. So all of this should be based upon the body's weight. The proper dosing has to be done. Anti-malarial that have been taken daily. Weekly, the chloroquine should be started 1 week before the arrival. So the chloroquine, okay, the chloroquine should be started 1 week before the arrival. Weekly mefloquine should preferably be started 2 to 3 weeks before the departure. So we have mefloquine, okay, mefloquine, chloroquine to be started 1 week before the arrival, and mefloquine to be started 2 to 3 weeks before the departure. All prophylactic drugs should be taken with unfailing regularity for the duration of the stay in the malaria risk areas, and it should be continued for 4 weeks after the last possible exposure to the infection. Is it clear? As a prophylaxis, the drug should be continued at least for 4 weeks after the last possible exposure to infection. As you know from the pathophysiology, that the RBCs, once the infected RBCs will release a lot of merozoites. These merozoites can attack the different RBCs, and again the relapse can occur, and within 48 to 72 hours, new fresh chills and rigors and fever can set in. And you can see this people who have stayed in the malaria high risk areas, they should continue the drugs for 4 weeks after the last possible exposure to the infection. Now let's see the recommendations for the long term. The risk of serious side effects which are associated with the long term prophylactic use of chloroquine and proguanil is comparatively low. However, anyone who has taken up to 300 mg of chloroquine for 5 years and require further prophylaxis should be screened twice yearly. So, if a person is taking 300 mg of chloroquine for a period of 5 years, okay, for a 5 years they require the further and still require the further prophylaxis, they should be screened twice yearly. The long term use of mefloquine, if the drug is tolerated for the short term, and then mefloquine does not accumulate during the long term intake. Okay, so we can see that the mefloquine is comparatively better because it is when it is tolerated for the short term, then it does not accumulate during the long term intake. Available data on the long term chemoprophylaxis with doxycycline is limited. Okay, the prophylaxis drug doxycycline being used as a prophylactic drug is limited. Then comes the National Malaria Eradication Program. The government of India launched this program in the year 1953. The malaria eradication program was launched in the year 1953. The national eradication program consists of various measures, that is administering the anti-malarial drugs. Chloroquine that is given at the 10 mg per kg dose for 3 days, and ancodiaquine for with 500 mg sulfamethopyrazine at 5 mg. Okay, what are the drugs which are given? So we see that the national malaria eradication program includes the chloroquine given at the dose of 10 mg per kg for 3 days, and along with that we have the ancodiaquine with 500 mg sulfamethoxypyrene 5 mg, 25 mg pyrimethamine with 500 mg sulfadoxine. The program has achieved a good result. Okay, with this administration the program has been achieving a good result. Thanks for watching. With this, we come to an end of the session malaria. I hope all the factors are clear to you. If you have any doubts in the concept, kindly put it down in the comment section. And if you like the video, don't forget to hit the like button and subscribe.